The patient was apparently alright 20 days back when he noticed pain in the upper abdomen, which was insidious in onset and gradually progressive. The pain was more localized in the central part of the upper abdomen. It was dull aching in character and a continuous type of pain, which was mild in intensity with a visual analog score scale of 1 to 2. He says the pain is increased after food intake and it improves after episodes of vomiting. There is no radiation of this pain to back or shoulder. About vomiting, the vomiting has also started.
What are the other questions you'll ask upper abdominal pain? There's a lot of disturbance. What are the other questions you'll ask in upper abdominal pain?
Along with that, any fever or jaundice, ma'am, along with the pain?
Fever and jaundice, or that the patient will say, I've got jaundice, no?
Yes, ma'am.
Any visible lump or abdominal distension?
It's got 20 days pain, which is insidious also, and upper abdominal pain.
And you said it increases with food. Is there any fullness after taking food? Is there early satiety? Is there any
yes,
all that you have to mention, no?
Distension.
Your slides are not seen.
Vomiting.
When does it come after eating? Does it come immediately or 1 or 2 hours later?
Sir, the pain is continuous, sir. It is there even at baseline. After eating for the first 1 to 2 hours, the pain increases in intensity. After that, he has an episode of vomiting. Post the vomiting, there is relief in pain, but still a continuous baseline pain remains.
In mild, you said it's only mild intensity. So there is some dull aching pain, which is mild in intensity and increased after food intake and improves after vomiting.
Yes.
What is this upper abdomen central? Is it upper abdomen central?
The epigastric region.
Okay. Any relation, any heartburn or any?
Early satiety.
No, sir.
Is there any early satiety or any postprandial bloat?
Yes, sir. He has early satiety and postprandial upper abdomen fullness, sir. With vomiting, actually, I described.
Okay. So that is important. So, okay.
Continue.
Any other question? Oh, let's see. Okay. Can we go to
the patient also yes, sir. The patient also complains of vomiting, which has started along with the onset of pain. It is about 1 to 2 episodes of vomiting per day, approximately 1 to 2 hours post meal. It contains partially digested food. Every time he says up to 2 cupfuls, around 400 to 500 ml each time. The vomitus is non-bilious, non-bloody, and no projectile vomiting. This is associated with postprandial upper abdomen fullness, which is relieved after vomiting.
Now, 1 minute. Just see that association. No? What are you connecting? No? Associated. What is associated postprandial upper abdomen? It's not the vomiting. It's not the vomiting. No? So that's what I'm saying. That's what I'm trying to tell. Yeah. Okay.
The patient does not complain of any. Sorry.
Yeah, go ahead. Weight loss.
The patient does not complain of any dysphagia, regurgitation of food, or any ball rolling movements in the abdomen. The patient also gives history of weight loss, around 4 kg of weight loss over past 1 month, from 71 kg to 67 kg. He also says he has associated early satiety and loss of appetite, which the onset on asking the patient says even before the onset of pain for the past 2 months, he feels that his appetite is reduced because of early satiety. And the patient is now able to consume only about 1/3 of his baseline intake as compared to what he used to eat 2 months back.
So what should your chief complaints be? No? The loss of anorexia and weight loss has started ahead of the abdominal pain. So you
started earlier.
Okay, that's how you start the history. No?
You should have started loss of appetite in early 2 months and followed by a central abdominal pain for 20 days. It's a continuous pain, increases after taking food and vomiting relieves it. Who is the discussant? Can you now discuss what are the...
Yes, sir.
Yeah, Majid.
Yeah. So there is early satiety and anorexia. So pathology looks likely in the stomach, as
No,
there
no,
is
no.
a partial relief of symptoms after vomiting, and food is partially digested, which is non-bilious. Most likely, the pathology is limited to the stomach because bile is not there.
What is
So
it?
which region
It
of the stomach?
it can be a gastric malignancy, or
No,
it
what
can
part of the
be
stomach you think it is affecting now?
Ajit, why
it,
there is vomiting? Vomiting is an
Why
important
is there
symptom
vomiting?
of this
yes,
patient. Why there is
Abdomen
vomiting?
pylori.
Which part of the
because,
stomach seems to be affected?
because there is a gastric outlet, because the gastric outlet, most likely there is a gastric outlet obstruction, and it may be involved in the in the antral area of the stomach, and may be malignant because patient's age is 66, and although symptoms are there from the last 20 days, however, his baseline symptoms are from the 2 months, can be malignant, can be ulcer disease as well.
That's all. Any other differentials?
And
No, let's
Increased
now
space
you are
can
occupant
be,
thinking.
lesions.
1 minute. Purva, just hold on.
yeah, can be lymphoma as well, ma'am, or it can be
No,
some external.
Any doctor, 1 minute. We're not talking. Can it be anything
No, no.
else other than gastric
See,
obstruction?
so it is
Can be
CSA.
something else, ma'am, which is causing obstruction.
What is that something else? What is that
Yeah,
something else?
pancreatic. It can be like a CA carcinoma of pancreas, or it can be a chronic pancreatitis background with pseudocyst, which is pushing on the stomach and causing obstructive symptoms.
The history is favoring that.
History is not typical, like, because there is not history suggestive of chronic pancreatitis.
Then,
No, what is unlikely to be? Why it is unlikely to be chronic pancreatitis?
Unlikely because, sir, there is no known history of pancreatitis or chronic abdominal pain in the past.
Okay, that is
However,
one
keeping
thing.
in mind that a patient has a history of.
If it is simple chronic pancreatitis, why would you explain the anorexia?
Simple chronic pancreatitis, sir, because there will be malabsorption.
No, then why it occurred all of a sudden 2 months ago? So if you entertain chronic pancreatitis, what additional problem should be entertained?
There should be, sir, long history there with the features of like malabsorption.
what percentage of patients with chronic pancreatitis have malabsorption? No, the questions will go in this direction. So let's come back. Can it be simple gastroparesis?
Gastroparesis, ma'am, can be, but less likely. So much of vomiting and
Oh yes, they'll have vomiting.
Gastroparesis also
Comes with vomiting.
a lot of fluid in the stomach and they will vomit, no?
yes, sir.
There is no
And-
mechanical obstruction. That's all.
And they will also have fullness of the upper abdomen. They'll feel full. They'll be bloated. They'll have uncertainty, and they'll vomit. They'll have weight loss. So
Yes, ma'am.
you cannot exclude that. Okay, so one is
Yes, ma'am.
gastroparesis, one is mechanical obstruction. Number 2, number 3, you have to consider possibility of a. Can it be a retroperitoneal mass?
Yes, ma'am.
What retroperitoneal mass? Because patient has got continuous pain, there's a dull ache, and then there's fullness, and then there's vomiting. And you mentioned that it is pain that is in the upper portion of the abdomen. Can it be a retroperitoneal mass?
Yes, ma'am, possible.
No, you have to defend yourself, doctor. We are suggesting, so try to defend or say no, just unlikely, less likely, or defend and say what are the possibilities. Bhavin?
Yes, ma'am.
We can't see the slides.
Yes, ma'am. Actually, I'm trying to share it again, ma'am. My device got disconnected. I've logged in from the other. Sorry for.
No, can you take up the discussion? Can it be a retroperitoneal mass? Purva?
Or retroperitoneal sarcoma or this or lymphadenopathy which is compressing
Lymphadenopathy never presents like gastric obstruction. What are the other possibilities? Any tumor, maybe it's a GIST tumor, just got an extrinsic
Just huge leiomyoma.
myoma. It has got an extrinsic component and that's causing compression. That's possibility, or it can be intramural. In an intramural GIST can also present like that. So you need a.
So when you analyze this patient's symptoms, it is predominantly early satiety and loss of appetite for 2 months. Okay. Now, gradually, he is not able to take food and it has come down to 1/3 of baseline take. Followed by which he has got 20 days of abdominal pain, which is increasing postprandially. And after 1 to 2 hours of eating, he is vomiting out all the stale food. So, early satiety, anorexia, and a weight loss in 2 months' time in a 66-year-old will tell you probably we are looking at some sort of a GI malignancy. Anatomically, the symptoms of anorexia and early satiety commonly occurs with which organ? Which organ? Early satiety and anorexia are the classical of
Stomach.
yes.
stomach. So stomach. In the stomach, initially, so it has started in the stomach. Now he is vomiting 2 to 3 hours after food. Okay?
Yes, sir.
2 to 3 hours after food. And the vomit relieves the abdominal pain. That means there is an obstruction, gastric outlet obstruction. So the lesion has to be somewhere in the antropyloric region.
Yes, sir.
And what could be the lesion? Most probably it will be malignant. If it is malignant, it should be one adenocarcinoma in the stomach, or it could be a lymphoma, right? Or there may be extraneously something obstructing the antropyloric. So it could be carcinoma body of pancreas or something which is infiltrating the pylorus. And as madam said, that can be a large retroperitoneal tumor which is displacing the antropyloric region and then producing obstruction. So this is how I think. So most probably it is within.
Yeah. Another important thing is you have to now just look at the no history. This is not the way to write the no history. No, focus your attention to the tumor. You've already thought it is probably a pathology in the stomach. So just think. You already said vomiting can be there. If the lesion is ulcerated, you can have a GI bleed. It can be an occult bleed. They may present as fatigue, anemia. They can have ascites as a complication. These are the things you have to highlight. Don't mention like this chronic pains and just all that.
Once you have a lesion in the stomach, according as madam said, you should probably look for a GI bleed. Okay. Has he had hematemesis? Has he had melena? Has he had any hematemesis or melena? Okay. How are his bowel movements? All those things have to be completed, as madam said, before you go into negative history. Okay. Negative history. Did he notice any high colored urine? Okay.
And
Did he have any cholestatic symptoms? All those things have to be completed before you say this.
Relevant to the patient, yeah. Not to say that he has acute pancreatitis in the past, jaundice and then pale stool, pruritus. How would you say, doctor? I mean, just think, how would you ask all these questions to a patient who does not have jaundice? Will you mention no history of jaundice, pale stool?
No history of, madam said, any fatigability, symptoms of chronic anemia like tiredness and palpitations. Did he have hematemesis or melena? Okay. And we are not worried. I don't think this pain, what it is ever happened. This has to probably come in the past history with everything. And probably now our So these are symptoms need to be, and how was this? Bowel symptoms. Okay. So all these things have to be completed before you go for a negative history.
Okay, sir. Sir, is bowel movements?
Consumption of corrosive will never come into this, no?
It never come, yeah.
Consumption of corrosive. Consumption of corrosive, patient would have come and told you earlier itself that we have corrosive. Somebody with corrosive injection has to come with abdominal and gastric outlet obstruction. It will come only after 8 weeks. And what corrosive will produce a pyloric scarring obstruction?
Acid.
Is it acid or alkali?
Sir, acid.
Sir,
Acid will cause antropyloric obstruction. So your history should finish off and no history of jaundice or any cholestasis. No history of any GI bleed or melena or hematemesis and other things. Okay.
So shall I read the negative no history of? Or?
Yeah, go ahead. But you need to have completed all those things before. Okay.
Okay, sir.
And you must you must mention the performance scale, you know. See, he's a person who's unwell. Just mention the performance scale. Did he have, before going to the past, was he investigated? Did he have an endoscopy? Did he have an ultrasound? Was anything done on him? These are the things that you have to highlight before going to the past. Yeah. Suppose he's had an endoscopy, he's had a CT. All this has to be highlighted.
Okay.
In the present history, and cannot keep it towards the end.
Okay. For these symptoms, actually, he is visited a doctor locally. He was asked to investigate further, but he did not wanted to get it investigated in Andaman, so he came here. So no investigations were done before this. No imaging or endoscopy was done before the patient came.
So in this slide where there is no history, most relevant things are altered bowel habits, that you have a GI bleed, swelling of legs and exertional breathlessness. Possibly that should have been added before you said no history of that. There is no consumption of corrosive. I don't know how did you correlate corrosive. The corrosive injection does not come with early satiety, isn't it? They have had a definite history of injection of corrosive. And after, and how long in the corrosive the fibrosis takes place?
So usually 4 to 6 weeks. Sir.
4 to 6 weeks. Okay. 4 to 6 weeks. Okay. No history of PUD is okay. Peptic ulcer disease is this thing.
No history suggestive of peptic ulcer.
So what did you ask for the history of peptic ulcer disease?
Sir, I asked for him recurrent episodes of upper abdomen pain or burning sensation, which was related to food, either increased with food or aggravated during fasting status, which was relieved after taking some medications like proton pump inhibitor. Usually such episodes will be precipitated during stressful events in the life. I asked for
peptic ulcer disease, you have duodenal ulcer, gastric ulcer. Duodenal ulcer pain is very classical. It will come 2 hours after food. Nocturnal frequency, gets relieved with food.
Yes, sir.
And if he has got any partial obstruction, he may vomit and vomit release pain. Gastric ulcer will sometimes have a pain. It's not necessarily related with, but sometimes gets aggravated with food. Okay. That is what is important. And patients may take some antacid to get the relief of the pain. Okay. Can we go to the next slide, ma'am?
Yeah, this altered bowel habits and all.
Yes, ma'am.
Altered bowel habits. Why did you ask for that?
Altered bowel habit.
Why did you ask for evening rise of temperature, cough, tuberculosis, TV contact? Doctor, just think you're sitting in the outpatient clinic. Would you spend so much of time asking all these questions? For a quick evaluation, quick assessment, what are the questions that you will ask? Will you ask this in this particular patient? Will you ask for history of tuberculosis?
No, ma'am. It's a very rare and a less common version.
Yeah, you will just say that there's no history of cough or fever. That's all, and just pass it on. And no past history of tuberculosis. And his family physician, whoever sees, would have at least done some basic tests, and would have told this is your problem. To that extent, you can mention that. I mean, you can mention tuberculosis, but don't mention TV contact. That means, suppose it comes to tuberculosis, they'll say you know the case, no? That's what will happen. And look at your blood. Hematemesis, swelling of the legs is coming right to the end of history after everything is over. So rephrase it, represent it, see that you have everything in order. Pertaining to the symptom, associated symptoms, performance scale, what are the nutritional deficiencies that took place because of anorexia and weight loss? Did he have uveitis, glossitis? Did he have edema of the leg? Was there any consequence? The nutrition is always missed. And did he have any breathlessness, palpitation, etc. because of occult blood loss? Keep the patient in mind and keep asking questions relevant to that. Hover around that. Just keep hovering around that. Okay, continue. Continue.
There is a. I changed the slide.
Okay, next slide.
There is no significant past or past medical or surgical history. No history of any GI malignancies in parents or siblings. The patient gives history of ethanol intake for last 30 years. He takes about 180 ml of whiskey 4 to 5 days a week, which accounts to about 24 units per week. His Cage score is 2 and Audit C score is 8. He also gives history of cigarette smoking, 30 cigarettes per day for past 30 years, which amounts to about 45 pack years. Other than that, his bowel habits, he is not altered. He passes once in 2 days motions. He takes mixed diet. His calorie intake is 700 calories per day with a requirement of 2000 calories. The deficit is 1300 kilocalories per day. His protein intake is 20 grams per day now with a deficit of 47 grams per day.
And can this be a hepatocellular carcinoma presenting in this manner? Upper abdominal pain, continuous pain.
Yes, ma'am. He has not had any signs of cirrhosis or liver decompensation in the past, ma'am, but possibility of hepatocellular carcinoma can still be there, ma'am, with a left lobe enlargement causing gastric.
Don't get into so much of a detail left lobe. It's a patient has got a dull, continuous pain in the upper abdomen. Would you consider with this background history of alcohol, anorexia and weight loss, a possible pathology in the liver that is presenting like this? We have seen patients where tumors of the liver have invaded or adjacent along lesser curve, you find that the tumor is actually grown into the stomach by infiltration. It's a dull continuous pain. Okay,
yes,
and there is vomiting. So these are all rare situations, but with the differentials of this, with the history of significant alcohol and the upper abdominal pain, is there a possibility that the patient actually has the CA of the small gastric, small ulcer, the gastric obstruction, and actually the HC or the metastatic lesion is the one that is predominant? Is it possible?
Yes, ma'am, it can be possible.
No, don't keep on agreeing with the examiner for everything. You have to defend and tell. Dr. VT and LV just tell them, no, just this bit how they should interact.
Ma'am,
Let
in
them
that
summarize
case,
and
patient
then
would have
discuss the
joined this.
possibilities again. Majid, what were you telling?
In that case, sir, if we consider large SCC which have infiltrated into the stomach,
Not HCC, metastatic lesion.
or metastasis, ma'am, in that case, will not patient have jaundice?
Not necessarily.
Not necessarily.
Okay.
You might have seen many cases wherein the liver is started with the meds and still patient has no jaundice, no? You might have
Exactly.
seen by this time. And sometimes you may even see large HCC without jaundice because the other lobe. You can even have a non-cirrhotic HCC where the other lobe may be functioning very well. So if the liver is fairly good in function, jaundice may be missing. I think you summarize and then list out the possibilities once again.
Yeah.
Possible, yeah.
Now we have the patient's history, his habits, and now you add up together and let us know.
Yes. To summarize my case, this is a 66-year-old male with alcohol use disorder with significant history of smoking, who is presented with upper abdomen pain associated with postprandial abdomen fullness and vomiting, with early satiety and significant weight loss, with no jaundice or GI bleed, with an ECOG performance status of 2/5. Syndromic diagnosis is gastric outlet obstruction with significant weight loss. Based on
And your differential
Based
Okay,
on the
define it.
patient's age, significant history of alcohol and smoking, and rapid onset of disease, rapid progression of disease with significant weight loss, I have considered malignant etiologies over benign etiologies. Amongst malignant etiologies, I will consider carcinoma stomach and carcinoma pancreas as the higher possibilities. And amongst benign etiologies, I have considered peptic stricture higher up. Other than this, the rare possibilities in malignant of carcinoma gallbladder and hepatocellular carcinoma is possible. And amongst the
Okay, carcinoma stomach you
benign
mentioned. Carcinoma stomach, which part?
carcinoma stomach in the antropyloric region, sir.
And carcinoma pancreas?
Carcinoma pancreas usually in the head of the pancreas, sir. Though they can
No, sir.
Now that's a problem. Head lesion producing outlet obstruction
Perfection.
and no jaundice.
No
Is
job.
that
Very
so
uncommon.
common?
no, sir. Commonly, a carcinoma of head of pancreas of a size enough to cause a gastric outlet obstruction will involve a biliary tree, and the patient will have obstructive pylorus.
So if you still want to consider carcinoma pancreas, which part you will consider? Which part of the
Sir,
pancreas?
The body and the uncinate process of pancreas can cause duodenal obstruction, sir, but that will be distal, so the patient will have
Okay,
bilious
if there is
vomiting.
duodenal obstruction, okay, for theoretical sake, if it is uncinate process and duodenal obstruction, what will be the type of vomiting? We were already
He
committed
will
that
have
it is non-bilious.
He will have a bilious vomiting, sir, in that
Okay,
case.
so we are committed to a non-bilious vomiting. So that means the lesion has to be proximal to the second part of duodenum. Okay. So among the head, body, and tail, which part can produce outlet obstruction with no jaundice?
Outlet obstruction.
Mass in the pancreas. Let us be little generic. Any mass in the pancreas producing outlet obstruction, the location in the absence of jaundice is likely to be in the body.
Okay, sir.
Okay, it can be large pancreatic mass lesion or it could be large cystic lesion also. Both can produce obstruction. Okay. Carcinoma of the gallbladder, okay, pain can present.
Again,
How do you explain the outlet obstruction in carcinoma
obstruction in
gallbladder?
carcinoma gallbladder. Yeah.
So carcinoma gallbladder can also have involvement of the duodenum, sir, and it can cause a
You mean to say
gastric
infiltration of the duodenum?
infiltration into the duodenum, sir.
Okay, the gallbladder is
Infiltration of the duodenum means where will the anatomically the tumor would have got in gallbladder? Is the neck body
Sir,
or funda?
Sir, in
which
the
part of the gallbladder is in touch with the duodenum or the antrum?
so the body.
You might have seen empty number of times during endoscopy the gallbladder impression on the stomach and the duodenum. Many times you have seen it. And which part of the gallbladder goes and touches the stomach or the duodenum? You can guess it actually.
Fundus of the duodenum.
Yeah.
Fundus of the.
.gb.
The other thing is your peptic stricture. There's no word for peptic stricture. No? What is this peptic stricture?
Actually, such a vague
Progress to
even for GRD stricture, people call it peptic stricture. No, that's the most common slang for esophageal stricture due to GRD. Okay, so I think your peptic stricture has to be much well defined. So, can you rephrase that peptic stricture?
So it can be a peptic ulcer disease which has progressed to form a stricture in
There's
the.
no word called peptic ulcer disease. It's called as acid
peptic
peptic
ulcer
disease.
is also vague.
It's acid peptic disease.
Acid peptic.
There's nothing called.
So even peptic ulcer is vague because a gastric ulcer, how often it presents without symptoms?
Please switch off your video.
Because between gastric ulcer and duodenal ulcer, which is more likely to present in the long term with an outlet obstruction?
Sir, more commonly duodenal ulcer presents with obstruction, sir.
Duodenal ulcer, but our patient doesn't have a prior history. Now, as per the age of onset, which is more likely, when does the duodenal ulcer present in which age group, and in which age group gastric ulcer presents? The usual type, not the drug induced.
So the duodenal ulcer presents in the younger age group, sir, middle age group, and gastric ulcer.
Yeah, adolescent and young adults. Okay, and gastric ulcer usually.
Gastric ulcer in the elderly age group, sir.
Not very elderly, past middle age,
42.
usual. This is not hard and fast rule, but among, so this patient is, how old is he? 57.
66 years old.
Okay, so if you presume that it is ulcer disease, the first time it has presented, it has to be gastric ulcer.
Gastric ulcer.
And any gastric ulcer, like a presentation occurring in a past middle-aged patient, you have to be highly suspicious, because it may be the presentation of a malignancy. It may present like ulcer disease, but ultimately the patient may be having malignancy. So you have to be always careful. And the chronic pancreatitis, do you strongly entertain that possibility?
Will you consider
No, sir.
this as a possibility?
Rarely in case of chronic pancreatitis, it can cause duodenal obstruction. Sir. Groove pancreatitis, it becomes chronic pancreatitis. It can go on to form a...
Before they get groove pancreatitis, what will be the presentation?
They will have an
Patients
episode of
with
acute
groove
pancreatitis.
Yeah, they'll be having recurrent
Episodes of
pain.
acute pancreatitis.
Then, at the point of time when the recurrent pain episodes causing acute exacerbation, when the head of the pancreas becomes very edematous and when impinges on the second part of the duodenum, you get vomiting. Prior to that, you will not get 20 days of pain. And this pain is preceded by anorexia and weight loss. This is not a feature of chronic pancreatitis. So you would have had recurrent pain for at least 2 to 3 months or 6 months before he gets into one of the acute exacerbations will produce enough edema and produce obstruction. Tuberculosis and Crohn's of, you're thinking of tuberculosis and Crohn's of stomach?
Oh, yes, sir. Gastroduodenal region, tuberculosis or Crohn's disease. It is very less common, sir, as per incidence.
No, what's the prevalence? How
Only
often have you seen tuberculosis and Crohn's present as gastric obstruction? What percentage?
I have not seen them. It is 1 to 2% of the total cases
Not
of
even
Crohn's
less than
disease or
0.2%. Be less than 0.5%. We've not seen any case so far. So many years of practice.
I have seen only one case, but that is again not outlet obstruction. It is a ulcer perforation. Crohn's of the stomach I have not seen. Duodenum I have seen, but not Crohn's.
Crohn's duodenum we have seen, but I have not seen
The stomach. Yeah.
tuberculosis of the. If tuberculosis of the duodenum, it may be some nodal tuberculosis which has infiltrated the duodenum. Very, very uncommon to have tuberculosis. Tuberculosis is mostly locorogenal. It involves predominantly the distal small bowel, ileocecal, and jejunal, like that. Okay.
I think you have to consider the possibility of gastroparesis in this patient. You cannot ignore that possibility. You cannot ignore the possibility of a metastatic lesion in the liver in a patient who has symptoms, because anorexia, weight loss has preceded all the other outlet obstruction symptoms. So these are the important differentials you have to consider. If on examination you found a large, hard, nodular liver, then that has to come up in your history taking. If the examination was
so if you see the presentation of anorexia and weight loss and early satiety preceding all the symptoms, then following malignancies you think of: 1, carcinoma stomach, carcinoma body of pancreas, and you will think of HCC can present like this, intrahepatic cholangioCA can come, gallbladder malignancy can come, but they always more or less come with pain, especially when it is in the neck of the gallbladder, and you need to think of a metastasis. Okay.
And
in a female, you should always think of an ovarian malignancy. Ovarian malignancy can also come with this, not a gastric outlet obstruction, but satiety, weight loss, and all those things. And ovarian pathology in a woman can either be a primary ovarian malignancy or Krukenberg tumor. So these things you need to think when you have these symptoms. And I said, please don't use peptic ulcer. Put it as duodenal ulcer with a gastric outlet obstruction. That will be yours. Carcinoma gallbladder, again, as VT sir said, and carcinoma gallbladder tend to come with pain. They come with for 1 or 2 months of right upper quadrant vague pain. Okay, that's how it is.
Ma'am, large just causing gastric outlet obstruction. Won't there be bleeding then patient?
No, not necessarily.
No, this is retroperitoneal gist.
Retroperitoneal, intramural.
you look at the retroperitoneal or exophytic gist from the bowel, they tend to produce symptoms more by displacing the organ.
Organs.
Yes,
Okay, so they can displace the organ and they come with vomiting, then you will find there's a gist. Okay, so an intraluminal will come even with a smaller tumor mass will produce symptoms. A retroperitoneal gist or exophytic gist generally tends to grow, displace the bowel or the GI tract, then produce symptoms. That is why by the time you diagnose, there are large tumors. Okay.
Okay, can move on.
Who is the other discussant? Dr. Purva, is it?
Yes, sir.
Yeah. Did you?
Let her take up the examination.
Yeah, examination. Okay. Can we go to the next slide, Doctor?
On examination, patient is conscious, cooperative, lying comfortably in bed with a pulse rate of 86 per minute, blood pressure of 130 by 70 millimeters of mercury in supine position, weight of 67 kg and height of 170 centimeter with a BMI of 23 kg per meter square. His frailty index is 1 by 5 on fried frailty index, pre-frail status. There is no pallor, icterus, pedal edema, lymphadenopathy or clubbing. There is no any peripheral signs of malignancies or chronic liver disease.
Just hold on. What are the things that you're looking for? Lymphadenopathy. Don't look at generalized statement lymphadenopathy. No? So what are you looking for, Purva?
Which groups of lymph nodes?
Lymphadenopathy specifically, I am looking
One
for.
minute. Just wait. No, Purva takes over.
Ma'am, left supraclavicular lymph node, we want to see for the Burkitt's lymph node and axillary lymph node. And also, if you are suspecting a lymphoma, in this case, we would want to do a generalized examination for the cervical and the submandibular lymph nodes also, and also check the Walder's ring.
How do you get this supraclavicular lymph node? How do you get this left supraclavicular? What's the mechanism?
The site of drainage of all the lymph nodes of the lymphatics of the stomach, it's ends in the left supraclavicular lymph node. So that is a sign of.
Trace the pathway. Trace the pathway.
The stomach, the lymphatics, they drain into the celiac group of lymph nodes, and from there.
Majid?
Yes, ma'am. The liver, spleen, and as well as stomach, they are.
You're not asking about liver, doctor. I'm asking you to stomach. Why?
Okay, ma'am. This celiac lymph nodes via the thoracic duct, they will go through the cisterna chyli to the left supraclavicular.
So from the thoracic duct, it goes to cisterna chyli, right?
Yes, ma'am.
Which is first?
First,
what is there in the abdomen? Which lymphatic
thoracic duct. First, sir, through this.
What is the name of the lymphatic channel in the retroperitoneum? The main lymphatic channel. Because thoracic duct gives you the clue, and it is in the thorax. Thoracic duct cannot be in the abdomen. Okay. So what comes before? From the lymph nodes, larger lymphatic channels, nodes, and then cisterna chyli. And as it ascends up and when it reaches the thorax, we call it thoracic duct.
Yes, sir.
Okay. And then what happens?
Where does it end?
Then it can go to sir left axillary. That's called Irish node.
How will the thoracic duct go to left axillary? Now you
Where does the thoracic duct drain into?
The thoracic duct drains into the.
1 minute. Let him answer. 1 minute, Bhavin. Just hold on. Just hold on.
Left supraclavicular. I'm not sure about it. I will read it.
Now tell Bhavin. Now you answer.
Ma'am, the thoracic duct drains into the superior vena cava, ma'am. On the way, the left supraclavicular lymph nodes also join the thoracic duct, ma'am. The right group directly drains into the SVC. So the meds from thoracic duct don't go to the right supraclavicular lymph node, but they can go to the left supraclavicular lymph node.
Thoracic duct goes to the left side. No? Very rarely you have a right thoracic duct. Most of the times it's all the left thoracic duct. But what really
I thought
happens
there was only one thoracic duct not
Yeah.
through thoracic ducts.
Yeah.
And instead of draining the superior vena cava, I thought it drains at the
It's
junction
some
of
fat.
jugular
Yeah.
and brachiocephalic vein.
And
Okay.
it is more of a fatty tissue. It's a subcutaneous fat where when it drains, it actually regurgitates into the thoracic duct, and that gives us a feeling of a left supraclavicular lymph node. It is not a true node. It is just a cutaneous tissue where all these veins join and the lymphatic pours into there. There's a regurgitation. This is Dr. Gaudas Chaudhary's famous teaching. There's a regurgitation into the proximal portion of the distal portion of the thoracic duct, and that appears as a subcutaneous, actually subcutaneous nodule that is called as a Virchow's node. Please learn, you must know the pathway, very important. An Irish node, no one knows the pathway. It is all no one knows the pathway, but it has been described, and they have described this as a finding, but no one really knows the pathway there. Okay, so left supra. So what are other things you look for? What are the cutaneous markers, Purva?
Ma'am, cutaneous markers, we will look for acanthosis nigricans. We will look for
Where will you
kind
look
of
for? Where will you look for?
ma'am, nape of the neck, dark velvety colored.
Where else do you get acanthosis? Then what are the other conditions?
Ma'am, in diabetes mellitus with insulin resistance, or in PCOS with features of insulin resistance
Okay,
or
good.
obesity.
So you have acanthosis nigricans. What else?
Ma'am, a sign of Lisartel area, that is the seborrheic keratitis, and also we will keratosis, and also we will look for the acanthosis basic sign of the thickening of the ungual tissue, and also dermatomyositis can also be rarely a presentation as a paraneoplastic syndrome.
Dermatomyositis and all will not come as a presentation of carcinoma of the stomach. Be very careful. Dermatomyositis, yeah, all that will not come in. Palmar keratosis, that's the other thing. There's more common with esophagus, but if the patient with dysphagia, it may overlap with the stomach. Okay, so please remember the lymphatic drainage. Why did you look for clubbing? Be very careful when you're speaking, doctor. Why should you look for clubbing in this patient? There's no indication at all. There's a short history.
Because of a significant issue of smoking, ma'am, I just mentioned it. Not relevant to the disease.
Okay, fine. What about nutritional deficiency? Cheilitis, glossitis, anemia, pallor?
Ma'am, no pallor, ma'am, no pedal edema, and no micronutrient deficiencies in the form of any loss of hair or angular cheilitis or oral ulcers.
Micronutrient includes trace elements, so be very careful when you use the terms. Be very simple and plain. Okay, move on.
On per abdomen examination, oral cavity examination.
Let us speak out.
Yes, ma'am. Oral cavity examination, tobacco dental stains are present. On inspection, upper abdomen there is fullness. Umbilicus is central and inverted. No flank fullness or visible gastric peristalsis, dilated abdominal veins or scars. On palpation, the abdomen is soft, non-tender, with no local rise of temperature, no palpable organomegaly or any palpable lump. On percussion, the liver sinus 13 centimeters and Tropp's case is resonant. Auscultation, normal vowel sounds are heard. Also, there is a succussion splash heard. And per rectal examination, the tone is normal and finger stained with yellow stain.
Interpret.
On inspection, a visible upper abdomen fullness is present, but there is no visible peristalsis or any presence of any lump. And also there is no evidence of any free fluid in the abdomen, and there is no hepatomegaly. One of the DDs we had
No, just tell doctor, don't keep repeating, just tell your interpretation. Give your interpretation to the findings.
What does upper abdominal fullness say there?
Sir, it could mean that there is a distended stomach because there is also succussion splash heard. So retention of fluid.
Because there may have been an antropyloric obstruction, there has been a thing. Okay.
Succussion splash.
What are the
So
precautions you
there
take?
is no VGP. You are surprised that there is no VGP. Why there is no VGP?
When will you not get a VGP?
Ma'am, a very long-standing gastric outlet obstruction, it could lead to a very dilated stomach, and then the peristalsis would not be.
Any other? In this situation, in this particular
In this situation, when thinking of a malignancy, when will the VGP be lost?
when will you not get peristalsis? Linitis plastica.
Linitis plastica. Okay.
You just get a fullness, but there'll be no visible gastric peristalsis in the same. And gastroparesis.
Percussion, I think you should also mention that there's no free fluid in the abdomen.
Yes.
Yes.
Okay.
And gastroparesis.
Yeah, you should look for a free
Gastroparesis.
fluid in the
That's
abdomen.
okay.
Now, what
Yes, there was
precautions
no
you
free
will take?
fluid in them.
What precautions you will take when you elicit a succussion splash?
Ma'am, first we have to explain the procedure to the patient, what we're going to be doing. Patient should be in a supine position with
No,
legs.
I'm not asking you how you elicit.
What are the things you should do?
What are the things?
When will you do?
When will you are looking for a succussion splash and it is positive. When all can succussion splash be positive?
In the abdominal causes, most commonly it will be positive in case of a gastric outlet obstruction with significant fluid residue in the stomach.
First and foremost, if the patient has taken food just half an hour
Taken
ago,
food, yes.
We have to ask the patient to stop. Has he stopped holding food, solid food for 4 hours, liquid for 2 hours at least? Gastric emptying time.
the other thing I wanted to ask was the vomiting that he had. Anytime he vomited in the morning of food taken the previous night? Marvin?
Sorry, ma'am.
Did
At
the
the time of
patient-
examination,
No. Did the patient mention with vomiting? Anytime did the patient have vomiting of food containing food taken the previous night?
no, ma'am. He says the same food, ma'am, but there is actually the food is partially digested. There is altered color, ma'am, of the food. He cannot recognize the previous.
I'm
No,
asking
ma'am,
a
no.
simple
He is
question.
not.
In the morning when he wakes up, does he induce vomiting and food contain and there's food partially digested food in the morning?
Yes, ma'am. Yes, ma'am.
Yes, sir. Yes or no?
Yes, ma'am. He contains food from the previous night, ma'am, when he vomits in the morning.
Previous night.
Yes.
So that is significant. That's really significant because that means definitely there's a evidence of. So how will you detect clinically a gastric outlet obstruction? Here you have one succussion splash. You have some. So what are the other signs that you look for?
Other than that,
So
ma'am, visible.
what are the history taking and clinical findings that we pick up from Purva?
Ma'am, in the there would be a history of abdominal distension and early satiety and fullness, and that would be typically relieved after vomiting. Vomiting, the patient would typically say 1 to 2 hours after consuming the meal, often early in the morning and containing the partially digested food, maybe foul-smelling food also.
What's a quantity?
Around 300 to 400 ml of food at least would be there, partially digested. With maybe coffee ground.
It's not food. It is just the liquid. The liquid that
Fine.
is, it's a liquid. Next.
There could be, the patient could give a history of a visible lump or a rolling ball sensation in the abdomen.
Next.
Next phase. Other systems.
No. Other signs.
Other signs, early satiety, postprandial fullness, involuntary weight loss, and pain.
All that is over, doctor. Clinical signs of gastric outlet obstruction.
Yes, ma'am. So patient, if he's having a long-standing outlet obstruction, he might be malnourished. We may see cutaneous markers.
BT, just get back to the clinical signs.
Visible gastric.
Systemic.
What are the other signs you look for? One is succussion splash. Number 2.
Visible gastric.
RTS.
What are the clinical signs? What are the clinical signs which will tell you that this patient is suffering from gastric outlet obstruction or other gastric stasis? We won't be always able to say gastric outlet obstruction. It could be obstruction or it could be stasis.
Upper abdominal distension or fullness. There may be visible peristalsis, succussion flash, and if we do the RTS aspiration test, that could be positive.
Which test?
Riles tube aspiration, the nasogastric aspiration test after half an hour. Saline loading test, sir. Saline
loading.
Saline loading test might be positive after half an hour.
In olden days, we used to do all those things. Yeah.
Then Ausculto percussion, scratch test, all these are all clinical signs.
What is ausculto percussion due to? What does it show, ausculto percussion?
The change in the resonance note, or when we keep the bell of the the diaphragm of the stethoscope on the
What does it tell
epigastrium.
you? What does it tell you?
What does it tell you?
The change in the
It's a
resonance.
dilated stomach.
Yes.
It outlines the stomach.
It outlines the stomach and shows it may be a dilated stomach. Okay.
These are all clinical signs. No one asks all these questions. With the introduction of endoscopy, all these, but when we were doing all these signs were often asked. But just see some of the old-time examiners, they ask some of these questions. No one does a saline load test, but you must know the ausculto percussion scratch test, overnight saline load test, overnight aspirate of more than 350 ml, and presence of BGP. So these are the 5 signs that you look for. When all can you get a mass in the epigastrium in a patient with CS stomach? Move on. And what are the components? And what are the components?
If there is a compression on the antrum, then the dilated stomach can present as a mass.
Dilated stomach will not present as a mass.
What are the components of a mass arising from the stomach in the case of a CS stomach? You are palpating a mass. Is it only the adenocarcinoma tissue or is it something else?
The lesser sac, and the omentum.
Lesser sac. Lesser sac is a sac.
Omentum.
Usually, I will make it very clear.
No.
Usually, when you feel a mass, it may not be simply due to that primary pathology. There could be additional components of the mass, which actually gives the size for that swelling. Okay, so we are asking you, what are the additional components of a mass which could contribute to the formation of the mass in adenocarcinoma of the stomach?
Sir, the peritoneum and the enlarged.
First and foremost is the tumor tissue itself. Okay, first you have to say that. Next is?
What's adjacent to it? Nodes.
Adjacent, yeah. Nodes.
What's adjacent?
Nodes.
Nodes. Then what else is adjacent to it? Mesentery.
What else is there? What else
Omentum, the omentum, at the stomach.
Omentum does not come there. It is just a reflection of the mesentery. Just a reflection. And what are the other components? So it can be nodes, it can be the tumor, it can be the reflection of the peritoneum, and occasionally if it perforates, one can even get a localized abscess. And linitis plastica. Linitis plastica is present as a mass. So these are 5 situations when you can feel a mass in the epigastrium. Okay? So these are some of the viva questions that we asked at this stage. Because when you're examining, you have to be very careful that you don't miss a lump or a mass. Okay, can we move on? Next slide. Other systems are normal. Okay, so your diagnosis remains the same. So now can we move on? Should we move on for so what's your diagnosis at the end of all this? Remains the same?
Same, ma'am. Additional findings we have found is upper abdomen fullness and succussion splash, ma'am. Succussion splash, though, is more common in benign causes of gastric outlet obstruction.
Gastroparesis should not be missed. I've seen patients with diabetes, hypothyroid state with huge dilated stomach, with weight loss and vomiting, and they're present with succussion splash. Because there's nothing here to say there's mechanical except for that weight, pain, some discomfort that you mentioned. To keep gastroparesis as one of the important differentials in this patient. Because you've not got anything positive, even on examination.
No, but here you've got a gastric outlet obstruction. So what? So now you have evinced, you have elicited a succussion splash. There is a gastric outlet obstruction. So what is your diagnosis will be?
So the succussion splash is more common in benign etiology, sir. But still, considering the age, significant weight loss, and rapid progression, I would still keep the same sequence of differentials.
Carcinoma stomach.
Followed by antropyloric region, sir. Followed by second possibility of ulcer in the antropyloric region, sir. And followed by that a carcinoma pancreas.
In the initial history, somebody mentioned about lymphoma, but that was not in the DD in the final. So you have just excluded lymphoma?
No,
And
sir,
lymphoma
but there is
present
no
with
significant.
outlet obstruction?
Yes, sir. Lymphoma can present with gastric outlet obstruction, sir.
So what are the different morphological ways of morphological appearance of lymphoma on the stomach?
Sir, it can present.
Margin?
Yeah, yes, ma'am. Yes, ma'am. Lymphomas, non-Hodgkin lymphoma,
Okay,
like
whichever you can select, no problem. NHL, because GI tract
DLBCL.
mostly it is NHL, no?
NHL.
Yes,
Mostly,
sir.
we don't entertain Hodgkin's in the GI tract when we discuss, no?
Diffuse large BCL is the more common, sir.
Okay, we are not asking you the theory. I am asking you what are the
What are the
morphology of the lesion, because only if you know the type of the lesion, then you can only imagine whether it can produce. Suppose it's a diffuse superficial lesion, as in the case of malt. Okay,
Yes, sir.
can it produce outlet obstruction?
Yes, sir. It can produce.
No.
No, because I said it. The prefix was very clear, no?
Very clear.
Diffuse and superficial.
Superficial,
Okay.
yeah.
So
Superficial.
mark doesn't. And therefore, the lymphoma can be in the form of a tumor, it can be form of ulcers, it can be nodule, it can be stricture, it can be diffuse infiltrative type. So many types can be there. So to produce outlet obstruction, the morphology must be sort of a growth-like lesion. Okay, if there's a bleed, we can say there is possibly ulceration, etc. Malt lymphoma, which is most commonly associated with H. pylori, seldom ever produce outlet obstruction. It's a superficial type of lesion. Okay. I think can we
Do you have
Extraluminal
carcinoma?
just we should keep as possibility, sir.
No mass.
Yeah.
Just unlikely because there's no lump now. So once the lump is not there, and at the
yeah, if with the just producing anal obstruction, it should be palpable.
it has to
Should
be
be
a mass.
palpable because it has to be such a huge lesion.
Huge
Okay.
mass.
Yeah.
So usually this is something that you should remember when there's a non-anatomical mass in the upper portion of the abdomen, invariably be a exophagic gist, non-anatomical. There'll be no anatomy to it. They're all usually non-anatomical lumps are usually gist tumors. In this particular patient, chronic pancreatitis, I will not consider. Tuberculosis, Crohn's, I will not consider in this particular patient. The patient has an onset of anorexia, weight loss, and then the patient has had history of gastric outlet obstruction.
Early setup.
Yeah.
Early
So
setup.
keep that in
And
order.
with the gastric outlet obstruction.
Yeah, keep that in order. Why should you bring in chronic pancreatitis at this stage?
So you have something obstructive antropyloric, give a differential diagnosis.
That's
Malignancy will be carcinoma stomach. Or
That's all.
inside the stomach, it could be lymphoma, not a malt lymphoma, it could be an NHL. Outside the stomach, infiltrating by the most common can be carcinoma pancreas. I don't think I'll consider carcinoma gallbladder, carcinoma chronic pancreatic tuberculosis, Crohn's. Okay.
And duodenal ulcer will come as important DD. The benign duodenal ulcer will
Benign will be duodenal ulcer with a gastric obstruction. Of course, you will think of a linitis plastica also.
How does
Very
gastric ulcer
uncommon.
produce outlet obstruction?
Margin.
Yes, sir.
Because stomach, the stomach is huge. You know, its diameter is much more than that of duodenum. So it is easy to produce a stricture. It is easy to get obstruction when there is a stricture in the duodenum, and it is not that easy to have a sort of a stricture of the entire stomach. So that is why it is unusual. So
Enteropyloric.
still it is possible. Still it is possible to have stricture of the stomach. In olden days, these things were described like hourglass stomach, etc., etc. Okay. Now such lesions are not seen. Earlier, we used to see such lesions which are prolonged, untreated gastric ulcers, finally developing into stricture in the body, in scissura, all those regions. But now I think it is practically unheard of, such lesions. Dr. Venkat, have you seen any case?
Not now.
Amongst the
Those times, all those things will be a body circumferential.
Generally, hourglass stomach affects the body. Which part of the stomach has got a highest predilection for a benign gastric ulcer?
Lesser curvature. Near the
Is
incision.
there any particular reason for that?
he got the clue from you. Why? There are 5 types of GU, no? Johnson's classification. There are 5 types. So which of them has a high acid output? Which of them has a low acid output?
Type 2 and 3 has high acid output, ma'am.
Yeah, the one that is juxtapyloric.
Which is
the juxtapyloric.
yeah.
The juxtapyloric ones behave like a DU. So the mid body and the proximal will have low acid, more proximal. Will have low acid. So somewhere around mid body will have near normal or high acid. Viti, any other answer for that?
Usually on the lesser curvature, we have got end arteries of OI, end arteries of OI, and due to ischemia, due to various causes, stress or whatever it is, or ischemia due to other problems, lesser curvature is maximally affected because lesser curvature is because stomach is highly vascular and lot of network connection is there all around the stomach. So it is practically impossible to produce ischemia of the stomach. But still, you have end arteries of the lesser curvature. Producing highly focal ischemia where the defense will not work properly. There are so much of defense against the formation of ulcer in the stomach. So that may not be possible because the vascularity is compromised at focal points along the lesser curvature. So these are known as end arteries of OI. Okay, when there is a discussion of CS stomach,
Any reason
invariably there
for
will be discussion of H. pylori. Invariably there will be discussion of atrophic gastritis, and so many things will automatically come. Okay, we don't go into
why is it in just a juxta-antropyloric region you have high acidity, and why is it in the stomach you have atrophic gastritis in H. pylori? Why there is low acid output in corpus, high output when H. pylori is there in the antrum?
The phenotype of H. pylori varies in both the locations, sir. The H. pylori phenotype which is there in the antrum predilection, it has a more of a tendency to produce duodenal ulcers. So it is
okay, Purva, have you heard of Koch's postulate? The Koch's postulate, it says that the organism has to be identified from the site of disease. Okay, in duodenal ulcer, you may get H. pylori, but extremely high chance that you pick up H. pylori from the antrum. So H. pylori is residing in the stomach and the ulcer is happening in the duodenum. That is what Professor Venkatakrishnan is asking you. Why there is such a dichotomy?
Why there is a thing such type?
Anyone can answer.
That's because H. pylori, when it is in the antropylori duodenal ulcer, it has got, in the other right stomach, it has got a parietal cell hyperplasia. Whereas H. pylori affects the stomach, it causes chronic active gastritis in the proximal stomach, and then that goes in for a atrophic gastritis. So you develop hypochlorhydria. Okay. That's the reason. Okay. Can we go to the next?
Yeah, investigation. Next is planning out the investigation. Who is discussing? Anyone else?
Come on. What? Majid or Purva?
Yeah. Yes, sir. We can start with the baseline investigation is in the form of hemogram to look for the anemia and the type of anemia, other indices, and then we can look the electrolyte abnormalities, sodium, potassium. We will do.
What will be the electrolyte abnormality you expect?
Yes, sir. There will be hypochloremic, hyponatremia, and hypokalemia with metabolic alkalosis with
Okay, fine. You know it. Okay, proceed. Once we know that you know it, we won't allow you to complete it.
They asked you for the mechanism of metabolic alkalosis, no?
Alkalosis,
Yeah.
hypochloremic, hyponatremic alkalosis.
What is the mechanism? What is the paradoxical? What is the paradox about it? What happens at the kidney level? So when you rectify an answer, no, they will get into the depth of this. So when you answer, you think an answer so that you don't fall into this trap. So it's a paradoxical effect of metabolic alkalosis because the changes are occurring in the reverse direction of the kidney. Okay, so that's okay, fine. Then what else you like to? Oh, you mentioned about type of anemia. You're worried about the type of anemia in this patient. You said you wanted to know the type of anemia. What?
It will not help more in although because we want to know, ma'am, anemia, the severity of anemia.
Yeah, but you mentioned type of anemia. You passed a passing statement on type of anemia. Can you get a macrocytic anemia?
Yeah, because he's an alcoholic, ma'am, chronic alcoholic.
No,
And
don't use the word alcoholic. The patient consumes that. But what? Any other thing?
alcohol use disorder. He has an alcohol
Anything
use.
else? Anything else? Anything else? Macrocytic?
Microcytic because of blood loss.
Intrinsic factor related?
Intrinsic factor deficiency will cause defective binding of butyryl band. That will cause
So
megaly.
where is it produced? Intrinsic factor.
In the body, ma'am. In
Which
the
cell? Which cell?
oxyntric, no, sorry, parietal cell. Sorry, parietal.
Yeah, parietal cell is oxyntic cell, the one that produces acid. So you can get, it's not that, but in this particular patient, looking for iron deficiency anemia. Okay, next, anything else you want? What's the next investigation that you'll ask for?
Next investigation we'll do, ma'am, liver biochemistry to see the nutritional assessment, albumin as well as enzymes to look for whether there is any liver involvement. Metastasis we were thinking.
Alphas and gamma GT are elevated.
Elevated.
When you look for LFT for nutrition assessment, doctor, be very careful when you're answering, okay? You know, you're making some passing statements, which the examiner, like you said, type of anemia. So I would caught
You want it to for,
you're not looking at the LFT for a nutrition assessment.
you are looking at for,
Okay, you're looking at
what are you looking for?
metastasis.
Alkaline phosphatase and
Gamma
gamma GT.
GT.
You're looking out for a
What?
metastasis. And if it's lymphoma, you're looking for infiltration in the liver. Okay.
Yes, sir.
Next.
So,
Any imaging?
so instead of that prefix, you could have simply said, I will look for liver biochemistry and specifically look for alkaline phosphatase and GGT and at albumin value, which will give me an idea about the nutritional status. Okay.
Exactly.
Unnecessarily adjectives to be avoided because that will attract a lot of unwanted questions. Okay. Never say anything which is unwanted, anything extra, which may create problem.
What's the next imaging procedure would like ahead of the endoscopy?
We would also do, ma'am, renal function to look creatinine, to do imaging cross section.
Okay, normal then.
We can do the initially we can do USG abdomen, which is cheap and non-invasive.
Don't say all that. You'll ask for chest X-ray. Chest X-ray shows metastatic lesion. It's over. Then it's only for you to make a diagnosis. And you also ask for an ultrasound scan of the abdomen, minimal fluid collection, any pelvic deposit. You can look at the liver. It's a simple bedside screening test, which is available in all the wards.
So in ultrasound, you look for thickening of the stomach. You look for nodes. You look for ascites. You look for any metastasis in the liver. Or you look for any, that's all. I think the patient is not jaundiced. So these are things you want to look for, isn't it?
Yeah, so we can go up to here and then what? And the last investigation of choice would be?
Cross-sectional imaging in the form of CT abdomen.
Before that, what will be the most specific investigation?
Upper GI endoscopy, sir.
How would you prepare the patient? How will you prepare the patient?
We'll keep patient, ma'am, nil for oral and do the nasogastric lavage.
With what tube? What type of tube?
Will you allow the patient to have a very heavy meal on the previous day and then put an nasogastric tube in the morning?
No, sir. We will not allow patient to have heavy meal, and we will put a nasogastric tube.
So what will you advise the patient to eat?
Liquid diet.
We can light liquid diet.
Okay, in a pakka gastric obstruction, yeah, you have to restrict heavy solid intake and make it liquid or semi-solid, mostly liquid diet and
Yes, sir.
And mostly overnight fast. After overnight fasting, you require aspiration because stomachs will still contain lot of food
That's
debris,
correct.
and it will not be possible to do a good endoscopy. What are the risks of doing endoscopy with a stomach with the full of food debris?
Aspiration.
First, visibility is very poor. You won't be able to make a correct diagnosis.
Yes, sir.
Number one. Number
That's
two,
the
very high risk of aspiration.
of aspiration.
Okay.
How will you, what if you said nasogastric tube? What's the diameter of the nasogastric tube that will take off all the food
All
matter?
the things.
What's the name of the tube that you use?
Is it simple Riles tube or some other tube?
Is it rice tube? Is it rice tube that you would use? Or some other tube?
Will rice particle come out through Riles tube?
Will rice
Digested
particle,
big
you know,
particles,
from here,
can it come through a Riles tube?
from here they will ask you what's the diameter, what's the length of the rice tube. No, the question will take off from here. So some of the questions are asked. So what is the other tube that you have for the stomach wash? Evol's tube, no?
In a
EWA.
poisoning and all, what is the tube? What is the tube which you insert into the stomach? In a patient with poisoning, no?
Poisoning,
The AD,
poisoning.
they do stomach wash, no? Gastric lavage. That's a different tube. It's a big bore tube.
Evol's tube, EWALDS, Evol's tube.
Okay, just know it in case you are asked these questions.
And patient is 63-year-old. See that you have an ECG done. See that he has got no cardiac issue. See that he does not have any dentures. All these are very, very important when you're preparing the patient. All right. So then we have the investigations now. Quickly go through it. Look at the hemoglobin, 15.2.
Look at the hemoglobin. Why is the hemoglobin 15.2?
10.2 grams.
Yeah.
What? Why is it?
He's warming hemoglobin is 15.2.
Purva, any explanation?
Smoker.
Hemoconcentration.
Smoker.
Okay.
Smoker.
And he's also a smoker. Creatinine,
Smoker.
sodium, everything is okay. LFE is generally normal. His albumin is too good. His albumin looks too good for the thing, and I
Too good, yeah. Maybe because of short
And there is no evidence of any.
What's the blood sugar? Thyroid, TFT, and blood sugar?
Ma'am, blood sugars are normal. Fasting blood sugar of around 96 or 100 something.
And thyroid?
Thyroid was not done.
These are the most important investigations that you would do for this patient. Okay, so I think you have only endoscopy
Next one.
picture. So what was the endoscopy finding? What was the endoscopy finding?
What is there?
Dr. Bhavin, tell us endoscopy finding.
Yes, ma'am. On endoscopy, ma'am, in the antrum, there was edematous mucosa, ma'am, and narrowing of the pyloric channel, ma'am. We tried to
There
negotiate.
is nodularity in the pylorus.
Pylorus,
You can
yes,
see
sir.
loss of vascularity. There is ulceration.
Ulcer was seen at one end of the pyloric channel. The scope could not be negotiated, but we could just see the duodenal mucosa beyond the pyloric channel. So a CRE balloon dilatation was done, and post that the scope could be negotiated, and biopsies were taken from that antropyloric ulcer and around the ulcer, the nodular mucosa around.
So with this morphology, what are your differential diagnosis endoscopy?
Purva.
Could be acid peptic disease, ma'am, or it could also be a gastric malignancy, a gastric ulcer.
First will be gastric
malignancy. More likely.
What is pseudopylorus?
Pseudopyloric metaplasia.
Pseudopyloric appearance in this scenario.
The thickening and edema causing narrowing and appearance.
Very often when there's an andropyloric ulcer, it will narrow the lumen to such an extent that it will appear like a pylorus, and you think that beyond that is duodenum. And generally, neoplasm is not seen in the duodenum, and therefore we don't think of taking a biopsy from duodenal ulcer. Some people do not take biopsy from the duodenum at all. Mostly they take only from gastric. But you could be actually seeing a gastric ulcer, which is wrongly considered as duodenal ulcer. So what we saw in this patient could still be that there is a narrowing at the site of the
Pyloric.
in the antropyloric region, and beyond what you are seeing duodenum is probably not duodenum at all. Unless you take a biopsy, you will not be able to say. So one must be very careful in such situations.
So this looks more like one deformed pyloric channel. It has got a nodularity. You can see the ulcer, and it's also thickened. So I think the other thing you could have done is just put on the NBI and see what it is. And this nowadays, I think you should put on the NBI and see whether it shows any loss of vascularity. Is there a line? As Sir said, then you dilated and went in. And went in, you're not able to see the D1. You've already gone into D2 after dilatation. And you have taken biopsies. Did you take any biopsies for H. pylori?
Yes, sir. H. pylori biopsies were taken, sir, from the antrum, sir.
Taken. So what is the recommendation of H. pylori biopsies in this sort of patients?
So for H.
How many biopsies you take?
You should take, sir, 5 biopsies.
What is the protocol known as?
Huh?
There's a name for that protocol.
Yes, sir.
What is that protocol?
So 2 biopsies from the antrum, 1 from the incisura angularis.
Some place.
Australia.
Some place in Australia.
Sydney.
Yeah.
Sydney protocol.
You have to take one from the lesser curve, one from the greater curve. You take preferably 2 biopsies, one from the antrum, and sometimes you from the angulus. So these are the 5 biopsies you need to take for H. pylori. I think it's correct, no, sir? Varghese, sir?
Yeah. 5 biopsies. Sydney protocol. Yeah. And how do you detect H. pylori? What are the tests for H. pylori?
Sir, from the biopsy tissue, we can do a rapid urease test on the biopsy tissue, sir. We can do a histopathological examination, HNE staining with GIMSA stain, sir, to look for H. pylori, sir. Warden staining for H. pylori.
Okay. From the tissue, these are the ways. Okay.
Yes, sir.
Why don't you do a culture? Because that's the way you do for other illnesses, no? To look for bacteria,
yes,
you have to do a culture.
So they are microaerophilic bacilli, sir. It is very difficult to culture them, sir. The culture medium and the incubation is difficult.
Most of the laboratory, microaerophilic, if you have good facilities, you can culture. That is how the people who discovered it found it out, no? So most of the laboratories may not have the Cambi pack or that microaerophilic situation, plus this highly selective culture medium. That's it. Apart from the microaerophilic, it requires a lot of inhibitors in the culture medium, and that culture medium may not be available in most of the laboratories. So they won't be able to, even if you ask for it, they won't be able to do it. Okay. So culture is not usually done unless it is for a research purpose. What are the other ways by which you detect H. pylori?
Sir, other than this, you can look for a stool antigen tester and urea breath tester.
Okay. What is the role of antibody test?
Antibody test is not reliable, sir, because even after eradication, it can persist for a long time. Even with remote infection, antibodies can come positive, sir. We usually
it only shows the patient has been exposed to it. It doesn't tell the current level of infection. Okay. Over to Professor Venkatekrishnan.
Yes, so what was the biopsy report?
So biopsy just showed chronic gastritis changes, sir, and it was negative for H. pylori.
Pyogenesis shows duodenum with the moderate to severe chronic active gastritis. GIMSA stain for H. pylori is negative.
Okay, so is it a gastric ulcer or a duodenal ulcer?
Sir, it's a gastric ulcer, sir.
Okay.
I think we should probably again do some biopsies and.
Yeah. You have to follow up the patient.
I think you have to repeat the biopsies and follow up. Just do a CT, no?
Yes, sir. We have done next CT scan of the abdomen, sir.
Yeah,
CCT abdomen.
Yeah.
Why do you want to do a CT? Because already the result is benign, no?
Sir, we are still not sure about whether it is benign, sir.
Okay, well, how?
Confirm
infiltration. Yeah, we could have missed the area of carcinoma, and this happens very often in gastric ulcers. All gastric ulcers must be considered malignant unless proven otherwise malignant. You have to strive to rule out malignancy. It's not duodenal ulcer. Duodenal ulcer to find malignancy is extremely rare. But in gastric ulcer, missing carcinoma is very high. So you have to be extremely careful. You have to rule out by all means. Okay.
Can somebody
So
interpret
CT
this?
abdomen.
Yeah. What does it show?
The CT abdomen showed a usually dilated stomach, sir, with fluid contents. The image on the right, sir, we can see the gastric outlet, sir, in the pyloric region. There is mild thickening of the wall, sir. But if we scroll down in the further images, there is no obstruction anywhere, sir, at the level of the.
Do you have further images?
No, sir, I have not uploaded
Is
that.
the pancreas normal?
Normal.
Pancreas is atrophied, sir. Volume
It is
of
atrophic,
pancreas.
and does it show?
Sir, that
I
is
don't
the
know.
vessel,
I
sir.
see some small intraparenchymal. I
This is
don't know.
Yeah, specks of
Total
calcification
vessel.
is there.
Specks of
So
calcification is there.
can it be chronic pancreatitis or due to
Chronic
some other
pancreatitis.
change?
Yes, sir. It can be changes of chronic pancreatitis because of chronic use of alcohol, sir.
Without pancreatitis, also some degree of atrophy can be due to old age, and some minimal specks of calcification can also occur due to old age. But he's 67 only, not too very old. Okay.
Matthew, Philip, you're around. I can see you. Can you come in kitchen and discuss about the endoscopic aspect of this presentation? Matthew?
Matthew has
Matthew
left. I
is-
have.
No, he's there. He's there. He's muted.
Is there
He's there. He's muted.
any other investigation available?
No, sir. That is also.
CT. So what
So
is
what's
the
the plan?
final?
What is your plan for management?
Ma'am, so we have done a CRE dilatation this time, ma'am. After that, there is some improvement in the symptom, though he is not completely improved, ma'am. We've asked him to follow up after 2 weeks for a repeat.
1 minute. Would you like to do gastric emptying study in this patient?
Gastric emptying study, ma'am. If the symptoms
After
are not
dilation,
improving after
post
dilatation,
dilation.
yes, ma'am. After repeated dilatation, if the symptoms are not improving, ma'am, we have
So
discharged the
we
patient.
should have-
No.
Doctor,
There is already a mechanical obstruction here. You are doing a gastric emptying study.
Yes, sir.
That does not help here. You do it only when there's a gastroparesis where your anthropolic region is absolutely normal. You may get a dilated stomach, but here you have seen a narrowing, you have seen a nodularity, you have done an ulceration. Biopsy shows chronic active gastritis, but still I think for H. pylori, I will repeat the biopsies and I will take more biopsies to look for H. pylori. You have taken only in the antrum. Probably we should go back to the Sydney protocol and take biopsies from the angulus. Sometimes when you have treated these patients, the H. pylori may move proximally. That's also is there. So you may have to take more proximal. As they said, lesser curve, greater curve, angulus, and then take biopsy and then say.
Most of the patients will be on H. pylori
Other
and
thing is
on TPA, and that will also reduce the chance of picking H. pylori.
The other thing why you did a CT, there are some nodes. Supposing there are perigastric nodes or something, then even though your biopsy is negative, it may give you a clue that probably you are still dealing with a malignancy. So it gives you an opportunity for you to go back and take more deeper biopsies. In a situation like this, you may have to take what is called the well biopsies. You keep deeper biopsies, so that sometimes you can get malignancy in that rather than picking up.
Especially when you have lesions in the wall, no? Even lesions in the wall, they need even
4-5 days.
Lineages, the initial biopsy may only show chronic gastritis. We may have to repeat the biopsy, take well biopsy from the same site. Sometimes even take snare sometimes, yeah.
The other thing is, just remember when there's a long-standing obstruction, to take time for the stomach tonicity. It will take at least 3 to 4 weeks for the tone to come back, because it is a dilated, formerly distended stomach with succussion slash. And narrowing, it may be benign. So in that situation, it takes a long time for the dilated stomach to regain its tonicity. It may take even 2 weeks. So you may have to wait for that.
Careful in such situation regarding lymphomas. Lymphomas can present like. So how have you treated this patient?
So we have started him. So this last week only we have seen the patient. So we have started him on PPI, sir. And after dilatation, he is able to tolerate liquid diet, sir, and semi-solid diet, sir. We have discharged him and asked to follow up after a week for a second session of after 2 weeks for a repeat session of endoscopy.
It's going to be benign. I think it looks more like a chronic, a duodenal ulcer with a deformed pyloric and antropyloric obstruction.
We called him after 2 weeks, sir, for a repeat endoscopy.
Bhavin, I have a slide to show. Is it possible to share that as a spotter?
Yes, ma'am.
Any learning points in this case can conclude, and if possible, I'll share. If not, we'll close. Just try once. AT and we can give some learning points. Please.
Yeah, I think this is a case with a predominant gastric outlet obstruction or symptoms of gastric stasis. So you must be able to differentiate between gastric stasis and outlet obstruction. The stasis due to mechanical obstruction is called outlet obstruction. There can be situations where you can have same set of symptoms but without obstruction. That happens in gastroparesis. Okay, so one must be able to confidently say gastroparesis, gastric outlet obstruction. Its symptomatology, like vomiting of undigested food 3 or 2 to 3 hours after food, vomiting of stale food. Stale food means undigested plus with a foul odor. Okay, and the signs: abdominal distension, succussion, splash, and then the investigation findings. So you must be able to tell all the points when you are asked about outlet obstruction. Majid, one point specifically I want to advise you is that, Majid, you know everything, but you try to say the explanation first, followed by, for example, when you ask about ultrasound, we did not ask you why you did ultrasound. Okay, so you are telling it is easily available, cheap, etc. Tell that only when you are asked. Otherwise, you can say by ultrasound, I can see whether there is ascites, whether there is liver mets, whether there is a lymph node. So your clinical answer must be first. And still, if why do you prefer it over some other thing? You can say it is cheap and easily available. But never put the explanation of doing it first unless asked for. Because the examiner must be wanting a clinical answer from you. Why are you doing ultrasound of the abdomen? Is to look for metastasis, lymph node, ascites, or mass, etc. Okay, and not because it is cheap and easily available. Because almost every hospital now will have ultrasound. No, so we don't have to explain it that way. Okay.
And the other thing is that succussion splash that you mentioned is more of a benign. Seldom you get. Linitis plastica you may get. But usually you don't get in a CA stomach involving the abdomen body. Succussion splash is uncommon. So that's one other thing that you can take a clue. That's why I said gastroparesis, you can get succussion splash.
Gastroparesis and benign causes of gastric outlet obstruction like pyloric channel ulcer, duodenal ulcer, or a duodenal stricture, all those things. Okay. I think we have not told you, we have not asked you about the treatment part. If a gastric ulcer, you have to treat. Unlike duodenal ulcer, you have to follow the patient with a repeat endoscopy and make sure that the ulcer has healed. Okay, in duodenal ulcer, we may leave them alone, but in gastric ulcer, you have to repeat the scopy, and if the ulcer is persistent, you have to repeat the biopsy, because that lingering doubt should be always there, whether we are dealing with a malignancy or not. Okay.
VT, you can see my slide. You can see my slide.
Yeah, I can see. Can you put it in the slideshow so that it will become slightly bigger?
I can see it in slideshow. It's full screen. You cannot see full screen? Can you see it? Because I can't see.
Yeah, we can see the slide now.
Okay, one of you, LVK and VT, please take up the questions. I'll keep moving. What is this? What is this?
What is the investigation? Which part of the body is seen? What are the findings? And then finally tell the diagnosis.
This is a yes, ma'am. This is a CT scan of the abdomen, axial view in an arterial contrast enhanced CT in the arterial phase.
Arterial phase, good. So that part is correct.
It is showing the liver, spleen, and stomach. There is a presence of fluid around the liver and spleen, probably ascites. The liver shows.
Good. And how does the liver look?
The liver is looking atrophied, sir, so shrunken in size. There is presence of a lesion, irregular lesion with inhomogeneous enhancement seen in the liver.
What is this?
There is something more, no?
You can see the arrow.
What are the things in the liver? What are the lesions in the liver?
LBK, you can see the arrow.
No, madam, I can't.
What is this? What is this hypodense? What is this hypodense lesion?
And a surrounding hypodense area around the lesion.
Is it entire lesion? Entire? Is it?
What is this? Okay, no, okay.
Let's see
I
the
just
arrow.
go on. So this is arterial phase. What's happening here?
Can you show other slides also?
Yeah.
There are many, no?
Can we see the other slides, ma'am?
I've moved on. Can you see the next slide?
No, ma'am. No.
No, we are not seeing.
Oh God. This slide you can't see. I'm moving it. You can't
No.
see the next slide. I don't know what to do.
Okay, from whatever
Okay.
you saw.
Ma'am, you can share once again, ma'am. You can share once again and see.
Whatever you have seen, try to tell us what are the possibilities. Once
Sir,
again,
this
what were
looks
the
like-
findings inside the liver?
Sir, there was an atrophic liver, sir. There is
Okay, agreed.
there is a mass lesion in the liver, sir, which is irregular and it has inhomogeneous contrast uptake, sir. Inhomogeneous enhancement with the contrast, sir, with surrounding two hypodense areas, sir. Around
And in the periphery, absolutely hypodense area.
hypodense areas. Yes, sir, and the presence of ascites in the abdomen.
Yeah, there's ascites, the surface
Ascites.
nodularity, shrunken liver, and there is a lesion which is enhancing patchily, and there is a hypodense area. Hypodense halo rather. Around the
Yes, sir,
mass.
hypodense halo.
Yeah.
I know it's a very nice presentation. I'm not able. Okay, it's come back again. Let me try once again. Can you see now? Can you see it?
No, ma'am.
No, we are not seeing.
Can you see?
No.
Can't see you. Oh God. Okay. then I'll
Ma'am,
get it.
this is Harish, ma'am. Ma'am, you can send me, ma'am.
Yeah.
I can share.
Okay, it's coming.
Yeah.
You can see now.
Yeah, now we can. Now it's moving.
Yes, ma'am.
We are
Yeah,
seeing the
now
second
what is it?
one.
Okay. This is what you saw. Now what is this phase?
This is what we
What
saw
is-
first, ma'am. So go to the next.
This is the next slide.
And what is this phase?
This is a portal venous phase.
And what's happening? What is happening?
Portal venous
What is
phase, ma'am.
happening?
The enhancement is the lesion is now becoming almost isodense with the surrounding liver, with still few hypodense.
What is it called? What is this called? Washout. No?
Washout.
Now can you tell what is
Washout,
what is,
early enhancement and early washout.
now tell what is this? When you get this enhancement and when you get this early washout?
Ma'am, this is usually seen in hepatocellular
No, just
carcinoma. ma'am.
explain the mechanism. After how many seconds would you take in an arterial phase? What happens to the liver? What happens to the lesion? And VT, please discuss this. That's why I kept this slide.
Ma'am, usually,
What is the normal CT appearance on a contrast CT, and how does it differ in an HEC? So if you are able to say these two, the answer will be correct.
so in the normal CT appearance, during the arterial phase, the vasculature enhances, the liver parenchyma does not enhance. During the portal phase, there is uniform enhancement of the liver.
Why
What
is
is
the
the
reason
reason?
for
Why?
that? All organs should be showing good contrast during the arterial phase. Why liver is not showing?
So the liver has a dual blood supply with portal vein and hepatic artery. The dominant blood supply, about 70 to 80% is from the portal vein.
80% is due to
So
portal
because of-
vein and only 20% is due to hepatic artery. Okay,
hepatic
so that
artery,
means
yeah.
during the hepatic artery phase, the visualization of the contrast will be little. Okay, agreed. That part is clear. So in the normal, you explained well. What happens in the HCC?
It's easy.
HCC, the blood supply of the tumor, the hepatocellular carcinoma tumor, is predominantly from the hepatic
Okay, it is
artery.
arterial.
So because
Okay,
of that,
correct.
there is hyper enhancement of the lesion during the arterial phase itself, whereas the parenchyma enhances later in the portal phase. And because there is no portal sinusoids in that area, the washout is also early.
Okay.
What happens to the
That's
background liver?
The
That continues to receive the portal venous, no?
Yes, ma'am. That continues to receive blood from the portal venous phase. So that is enhancing in the portal phase, whereas the lesion becomes hypodense in the portal phase.
Now, what phase is this? Third picture. What can you see now? You're able to see the third?
Yes, ma'am.
Now, what is this phase?
This is probably delayed phase, ma'am, in which it becomes
Yeah, delayed
uniform.
phase. So now,
The
can you
enhancement
guess?
becomes.
What can you see? Now, can you see the lesion?
Yes, ma'am. Now the lesion is seen as hypodense compared to the surrounding area. The enhancement is.
Can it be just with this? Supposing the saloon was kept, can it be an FNH?
Because
The
yeah,
discussion
the central region appears hypodense, no?
Central region.
The central hypodense area could be a necrotic area in
it
the
can be a
center.
necrotic area because in F.
So when do they necrose?
When will you get necrosis?
In the larger tumors, when the tumor size is too large, ma'am, the arterial supply is not able to match up with the growth of tumor, get necrosis.
That's possible, or post-TACE.
Post-embolization.
Post-TACE also you can get necrosis. Yeah, post-TACE. Now, what is this? What is this? Same patient.
This is a coronal section of the abdomen.
What's happening?
The arterial phase only, ma'am, this also.
Arterial, where is it heading towards? Where is it heading towards? Where is it heading towards? Now see this. Where is it heading towards? What's happening to the IVC?
It is compressing.
This is IVC involvement. It's an IVC involvement.
Compressing the IVC.
Not compressing, it's invading. The artery, the same arterial thing that you saw in the axial phase is now actually extending into the IVC.
IVC, yes, ma'am. There is enhancement within the vein.
There's an enhancement within the vein. See this. You can see it so beautifully. No?
Yes, ma'am.
Yeah, you can see it enhancing. So the arterial phase, you can see the arteries dilated. You can see the arterial enhancement of the tumor, and it is heading towards the IVC. So now, how will you manage this patient? What BCLC stage will it be, and how will you manage? Yeah, you can see this. Can you see this IVC? Can you see the IVC?
Yes, ma'am.
Can you see this coronal section?
Yes, ma'am. You can see the IVC along.
IVC, yeah. Yeah. The IVC is compressed. It is involved by the tumor. You can see the whole tumor is invading into the IVC. Now, how will you manage this patient? Quickly tell. Look at this. Look at this lesion going into the IVC. How will you manage this patient? This is beautiful. Look at this.
This will be BCLC stage C, ma'am. At stage, ma'am.
BCLC C because of
invasion into the IVC.
vascular, because of vascular thrombosis.
Extrahepatic vascular invasion.
So, how will you manage this patient? How is it classified now? What is a modified BCLC? What is modified BCLC? You had this question for the DNA exam, no? Last time.
Yes, ma'am. For modified BCLC, ma'am, we have this 0, A, B, C, and D, ma'am. We can downstage the tumor, and if we can make it resectable.
No. C. How is the C? How is the C modified and modified BCLC?
Progression.
So, what will be the first line drug in this patient?
And the first line will be chemotherapy. In the chemotherapy, the first line drug is the immunotherapy, ma'am. The atezolizumab with
bevacizumab. That will be the first line. So here they will ask you all these questions. What's the first line? What will be the second line? The modified classification gives it beautifully. That figure that is there, you should know that. Okay. Is there any rule for tear in this patient?
Ma'am, yes, ma'am. We can do tear if the patient is inoperable, ma'am. He has advanced cirrhosis. Then we can do.
You can't operate on. You can't operate
This patient is
on.
this patient.
Ma'am, tear we can do to downsize the tumor for reducing the tumor load. We can do tear, ma'am. But otherwise, chemotherapy will be the line of choice.
If you have a vein infection, very close to the capsule or to this thing, we don't do tear. You can do SBRT. In fact, SBRT will stereotactic.
I want to discuss SBRT. Yeah. Today there's a major role for SBRT.
Madam, I'll take leave, man. The restaurant will close now. So
yeah, we're also leaving. they're also leaving. Yeah.
Okay.
Thank you very much. So just read
Okay.
about this advanced SEC and its management only for that. Okay.
Yes, ma'am.
Okay. Thank you. Thank you, NVK, for
Thank you, ma'am.
chipping in. Thank you, VT.
Thank you, ma'am. Thank you,
Okay,
sir.
sir. Tomorrow we'll
I
catch
just
up.
wanted to show the
Thank you.
assessment. Yeah.
Ma'am. Thank you,
Okay.
sir.
Bye. Good night. Good night.
Thank you, ma'am. Thank you, sir.
Thank you.